Did you know that having one fracture doubles your risk for another fracture, and that each decade after the age of 50, we lose 1 centimeter in height due to compression of our vertebra? Now, with us today is Dr. Nick Birch. Nick is a consultant spinal and bone health specialist, a fellow of the British Orthopaedic Association, and a member of the Royal Osteoporosis Society. Nick has published widely on orthopedic topics during his career and has taken part in 35 peer-reviewed papers. But for the last 28 years, Nick has run a busy spinal and bone health practice in the UK. Now, today we're going to discuss osteoporosis in a way that might just change the way you think about bone health. Nick is a pioneer of a new and validated bone assessment measure called REMS, which is now available in Australia. In part one, we're going to cover all the bone-related information, the intricacies of how your bone is constantly changing, what is DEXA, what is REMS, and a novel new marker called the Fragility Index, which is a critical must-know. And then finally, some treatment options for osteoporosis. Then in part two, we're going to use me as a guinea pig in a case study and look at both my REMS and DEXA to see what we can learn. Welcome, Nick. Thank you so much for joining us today.
Thank you very much. Love to see you, Em, and thank you for inviting me to be part of your podcast. It's great.
Not a problem. Now, tell us a little bit about yourself and how you became a specialist in osteoporosis.
I trained as an orthopedic surgeon and then in the 1990s specialized in spinal surgery. One of the things at that time, because DEXA was quite new in the 1990s, it had been developed in the 1980s, and we were beginning to get DEXA results coming through. So we thought this was fantastic that we could understand at last women's bone density and their bone health. But it became quite quickly apparent that DEXA was telling us one thing, and sometimes the patient was telling us something else. And that's because I was operating them. So I was actually inserting screws into their spine and taking bits of bone. And sometimes we'd see patients who had very low bone density on DEXA, but their bones were really tough. You put a screw in, it's really hard work to get the screw into the spine. And others that you'd be putting a screw in and they said, oh, DEXA says that your bone density is fine. Actually, it felt almost like putting it into cheese. So in reality, we had a mismatch. And so I started to get really interested in the late 1990s, early 2000s. And then over the last 20 years, I've become more so. And it all came together in 2015 when I needed a bone density machine to scan some paralyzed patients. And there wasn't one out there because DEXA was going to be able to manage a paralyzed patient with a ventilator. And that's when REMS came up in 2018. And that's when I started to pivot. So that's why I got here.
Fascinating. And your knowledge is very broad. You've been on the tools, so to speak, and you've done the research. You've got so many different angles on this extremely important topic of osteoporosis.
Yeah, I mean, I've been over the years really sort of very keen on education. So to educate people, you've got to know it yourself. I've been the spinal editor for the Bone and Joint Journal, which is the UK's premier orthopedic peer review journal. And I've lectured all around the world on a variety of topics. And as you said in your kind intro, co-author on 35 peer-reviewed papers, the latest of which came out just a month ago, which was our practice parameters paper regarding how do you deliver REMS in a quality control way. So I keep writing, keep publishing, and keep myself educated across a whole range of things. What's interesting about bone health is it doesn't just cover one aspect of the human body. It is so many aspects. And so every clinic, I will see a woman who's had DEXA scan for some reason, and she's got a different condition. And it's like going back to medical school 40 years ago. So just learning all this stuff again, it's good.
Yeah, I feel like you can never stop learning when you work in this realm of health. I love that you've got that mindset too.
And when doctors stop being curious, they ought to retire. I'm still very curious.
So am I. So am I. Now, I want to set the scene of bone health in Australia because I'm sure it's pretty similar in the UK. Over 1 million Australians have osteoporosis, and in those aged 50 years and over, 66% have osteoporosis or osteopenia. And women over 50 are 4 times more likely to develop osteoporosis than men. Now, this is my age group, so I'm really in this to learn. Now, this is usually due to less overall bone mass, longer lifespans, and pregnancy, and as well as the hormone changes of menopause. But the thing is that osteoporosis patients often experience a delay in diagnosis, and serious disability and reduced life expectancy can occur because it just goes unnoticed. Bone health is so overlooked and under-investigated. And Nick, I know you want to change that, as do I. Before we go any further, though, what's the definition of osteoporosis and how is it different to osteopenia?
The osteoporosis is reduced bone mass and decreased bone fragility. So that's the definition that was put out by the experts back in the 1990s. It used to be only diagnosed when we're fractured, but after DEXA came along, we could then make the diagnosis using bone mineral density. So the key here is that you've got to separate out the two. Bone quality and bone strength are more than just bone density, more than just the actual sort of microarchitecture. It's also about, can a woman's bones repair themselves? Does she have enough resources internally to allow her bones to remain healthy? So the whole thing is multifaceted. But osteoporosis, low bone density with increased fragility, therefore increasing the woman's risk of future fractures. Osteopenia was a term that was defined by the World Health Organization's committee that decided on the diagnosis of osteoporosis. And they met in 1992 in a hotel at the top of the Spanish Steps in Rome. It was a hot June, and they were bouncing arguments around for 2 days, and they couldn't really work out how to define osteoporosis. And at one point, because they wanted to get off on a Friday afternoon, go and have a nice swim and maybe a cocktail, somebody just said, hey, let's just draw this line across this graph. Everybody below that has osteoporosis, everybody above that's normal. And somebody else said, well, hang on a second, how can you go from normal to osteoporosis so quickly? They said, well, look, let's put a little bit in between. We call that osteopenia. We don't ever expect that to be a diagnosis. That's for researchers and public health doctors to just have a concept of how do you change. And that's where the diagnosis of osteopenia came from. But within 6 weeks, it effectively been weaponized by Merck, Sharp and Dohme. And they had then decided that this was not normal. Therefore, it was a disease. And therefore, they had a massive sales pitch and push with their Fosamax drug, which was the first anti-osteoporosis drug. And that then turned it into a blockbuster drug. So the term osteopenia is a convenience term. I mean, it doesn't mean it's a disease. Certainly, it's different. Osteoporosis, in many women who have got low bone density and increased fragility, sure, they have a disease. But in many women who have osteopenia with normal bone toughness, there is no disease there.
I love that reframe of osteopenia not being a disease state, because working clinically, I have a lot of women that come in with their DEXAs and they're kind of really petrified that they have osteopenia and they're really in that fear state. So I love how you've explained where the term comes from and what it actually means, and that it's not a disease state. Because when we're talking about bones, bones are metabolically really active and they remodel. But how do they do that? Can you just give our listeners a little bit of what happens within the bones?
Yeah, so bones are a complex structure, primarily made up of collagen and essentially protein and calcium, with a whole bunch of other atoms in there, forming this very tough, very elastic, very metabolically dynamic tissue. It is one of the most active metabolic tissues in the body. And of course, what it does, it provides support for all the organs and allows us to be upright and stand. So protection against external forces. It plays a big role in red blood cell production and white blood cell production, stores minerals, particularly calcium and phosphorus. And it's involved in regulation of your hormones. And of course, it stores energy in its yellow fats. It's continuously being remodeled. So this process of remodeling is where you've got old bone that's no longer needed where it is right now, taken away, new bone laid down, and then sculpted to make really good, strong bone. And that process of remodeling continues throughout life. However, after the menopause, what happens with remodeling is that because the estrogen is so key to allowing remodeling to be balanced, there's an imbalance. And so there's too much of the osteoclast activity. The osteoclasts are the cells taking bones away. They're the sculpting cells. And the osteoblasts are the cells that lay down bone. But the osteoblasts lay down bone in a way that's disorganized. And you need the osteoclasts to come in there and clean it up and turn it into a useful bit of bone. If you've got just osteoclasts and effectively you've got too many of them, it takes way too much bone. And so then you begin to get reduced bone mass and increased fragility because the structure is degraded. So this is really how postmenopausal osteoporosis comes about, because it's the disruption of the normal remodeling system.
fascinating to me how bones have so many purposes within the body, because I think most of us initially think that the bones are just static things that are in our body, whereas they're so dynamic and they have so many functions within the body. But when it comes to traditional bone mineral density, I know we're going to dive into this, how is osteoporosis actually diagnosed?
So two ways to diagnose osteoporosis, one of which is that you have a bone mineral density test, the DEXA test, and you will be given T-score. Now, T-scores are the measure of you compared to a young, healthy woman. It's women between the age of 20 and 29, coming up to age 30, which is the definition of what's called peak bone mass. So this is when you've got your very best bone. So what a T-score does is it tells you how far away from that peak bone mass you are. If you've got a positive T-score, then you're above the 30-year-old's bone density. If it's negative, it's below. And the definition is then based upon these T-scores. So a T-score of -1, being mathematically and statistically, if you put all the results of your tests on a graph, you get a bell shape, you get this normal distribution. Slice that up into equal segments and you get standard deviations, and a T-score is just standard deviations. So -1 T-score is -1 standard deviation below the mode value. And the mode is the most common, the values in normal distribution. I know that's a bit technical, but your listeners are all scientists and doctors, so they understand these things. But -1 standard deviation is a -1 T-score, and anything better than that is normal bone density. If it's below -2.5, it's defined as osteoporosis. And if it's between -1 and -2.5, then you have this gray zone, this osteopenia or reduced bone density. So that's how the diagnosis is made on the basis of T-scores. The second way, however, is if you have had a fragility fracture and you have osteopenia, it is considered clinically that you have osteoporosis. Right. And that goes back to the old days when the only way to diagnose osteoporosis was to have a fragility fracture. So you might have non-osteoporotic bone density on the DEXA. You've had a fragility fracture, indicating, therefore, that you do have a problem, and therefore you'd be given a clinical diagnosis of osteoporosis.
There's a lot in that, but essentially osteoporosis is more than 2.5 standard deviations away from what your bones would have been like when you were 29, 30. Now, when we're looking at the new and emerging technology that can assess bone mineral density, I want to look at REMS, or radio frequency echographic multispectrometry. I heard about this actually from a patient. Patients always teach me so much. And she told me that there was one clinic in Melbourne that were offering this testing to assess bone mineral density for her. And so I rang David from Ecolite in Melbourne, who has brought it to Australia. And I was so impressed with the research that after talking to David quite a lot and looking at all the papers and the research, I facilitated bringing Ecolite to Sydney, and they're now working from my brother's physiotherapy practice. And last October, Nick came up to Sydney to do my REMS because he came up to do a bit of an intro to it all. And I have to say, since then, I've referred so many patients for a baseline REMS, from a 35-year-old to a 94-year-old. This technology, I feel, is for everybody. But can you explain how REMS works and what it measures and the difference between a REMS and a traditional DEXA?
So REMS is based upon ultrasound. And if we go back into history, there was something called quantitative ultrasound. So what that was usually was measuring how sound was then transmitted through bone. And you put your heel into a machine, and it would then put a pulse of sound from one side, and it would pick it up on the other side, and it would measure what's called the speed of sound across the heel bone, and something called broadband attenuation. Long and short was how was sound changed going through bone. And then in the early 2000s, the very clever ultrasound scientists in Rome at the National Research Laboratory started wondering whether you could look at the way that ultrasound was interacting with bone in a slightly different way. And they wanted to look at how the sound was reflected. So effectively what the ultrasound does is it pulses sound out of the bone, and then it reflects back. It's called an echo. But when it comes back, it's not coming back as a sound wave, it comes back as a radio frequency wave, so it changes. If you pick up all of those radio frequency waves, you can then make a curve. You've got what's called a spectrum of all of the radio frequency waves. That means you can then compare that spectrum to a known spectrum from something that's been analyzed in the laboratory, and you can have bone that's been taken from people who have fractured and those who haven't fractured. and you know what their spectra are. So
Right.
you can then take Emma's spectrum and say, okay, well, your spectrum, Emma, is either closer to someone who hasn't fractured or someone who has fractured. And between the two, because there's lots and lots of individual data points in the database, you can say, well, look, you are now 92.3% closer to someone who hasn't fractured. Therefore, your T-score is this, or your bone density is this. So that's the first thing that the REMS does. The second thing that REMS does is to look at your bone architecture. So then it produces effectively another picture that then compares the quality of your bone to people who haven't fractured and those who have fractured and everything in between. So that's then the fragility score. So you've then got your bone density, T-score, your Z-score, your fragility score, which is new because it isn't possible with DEXA to measure the fragility of bone in the hip. You can on the spine if they have something called TBS, trabecular bone score added, but you can't do it in the hip with DEXA. And then thirdly, if you have the model added, you can also measure body composition, which DEXA can measure if you have also that as well. So that's really quite useful. So we know what somebody's body mass index is, we know what their ideal weight is, and then we can measure their weight against ideal weight for them. And we'd also measure their fat, which is mostly visceral fat. And that gives you an overall understanding of your metabolic condition. So that's what REMS can do. And it is something better than DEXA in the sense that it's measuring fragility in a way that DEXA can't in the hips.
What I find fascinating about it, it's a lot. I think about, and tell me if I'm wrong, I think about REMS as telling me sort of the toughness of the bone, kind of the bone quality. And I feel that it's more applicable to real life. So when I'm working face to face with women all day long and they want to know what the reality is with their bones, I feel like REMS is giving us more information, a better quality information to make clinical decisions off the back of.
I think you're right. And let me give you an example. So do you know what the smallest bird in the animal kingdom is? It's the bee hummingbird in Cuba. 5 centimeters long, it weighs grams. Hovers and flutters her wings 80 times a second to get the nectar out of the plant. Okay, now bear that in mind. Okay, what's the largest animal in the animal kingdom?
Elephant.
Elephant weighs about 2 tons. Clearly, because the hummingbird is so light, she must have ultra low bone density. But the elephant is so heavy, she must have ultra high bone density. But the elephant occasionally has to run at 35, 40 kilometers an hour, particularly if a lion is bothering her calf. So she therefore has to have very tough bone. And go back to the hummingbird, to flap her wings 80 times a second has to have very tough bone. What's therefore the link between the hummingbird and the elephant? It's not bone density, it's bone toughness.
Really?
And that's what you are observing in your clinic. And that is that you can have a very slight woman who may have a very low bone density because she's slight. But if she's really active and she's doing a lot of physical activity, her bone toughness is going to be fantastic. So a ballerina is a good example. So ballerinas, all are very lightweight ladies, by definition they are. So therefore they will have a low bone density, but they are very, very tough and their bone toughness is phenomenal. Therefore they don't fracture, they might fall over. So for instance, they're dancing, there's a throw up in the air, the ballet dancer, he throws the ballerina up 2 meters, she comes down, he misses the catch, she bounces. If it was all down to just the bone density, because her bone density is relatively low, you'd expect her to break every time, but she doesn't because she's got really good tough bone. So you're quite right. It is the combination of the two. And you can have a woman with a low bone density, but very good bone toughness who's completely healthy. But you can also have someone who's exactly the opposite. And that is you can have someone with a high bone density because they have a high body mass index and the two are very related. But they're not exercising because they might not be able to, because they might have arthritis or diabetes, and their bone toughness is not that great. So therefore they are more likely to fracture.
Yeah, I find it fascinating because when we look at just DEXA alone, it's going to paint a slightly skewed picture to what the reality is because of all of those variables.
I agree, because if you're only looking at one aspect of it, it's a bit like wearing blinkers, isn't it? If you're looking at blinkers, you only see directly what's in front of you. You can't see the world. The big problem about any test, if it only measures one part of what you're trying to measure, it's not going to be a completely satisfactory way to measure it. Let's go back to the definition of osteoporosis. Okay, the osteoporosis definition is characterized by reduced bone density and increased bone fragility. i.e. reduced bone toughness. Without the two, you cannot fully characterize a woman's skeleton.
Yeah. So this is where I want to really educate people about taking the fear out of this bone situation and the importance of being proactive in relation to the toughness of your bone. But what does the research say about the fragility index? Where are we at with the research on that score?
So the research first started, the first paper was published in 2015 when then the Ecolite, the National Research Laboratories, published the actual methodology of actually how it was then produced. Subsequently, then there have been, I think it's 15 or 17 papers on the fragility score have been published. The most useful one is the one from 2023 by Paolo Bazzani. And in that, they had just under 2,000 patients, men and women, in Italy, who they followed for up to 5 years. Beginning of the study, they all had a DEXA and a REMS scan. And the REMS was the bone density as well as the fragility score. The DEXA was obviously just the bone density. And then when they followed them out, what they found was that the REMS and DEXA T scores were equally accurate in predicting whether a person would fracture in that subsequent time. They weren't that good at it. Neither of them were, because it's only part of it. The fragility score was much better. And that was better for women in the lumbar spine, in the hip, and men in the spine and hip. So what that told us was that when we're thinking about the likelihood of a woman fracturing, if we take just the bone density, we're only going to get a partial glimpse of why she might or might not fracture. We need toughness on top of that, and that's probably more important. So as I said earlier, if you have someone who has a low bone density, but they've got really good toughness, they can do what they like pretty much. They would have to work very hard to break. They really have to clatter themselves. Whereas someone who's got very significant fragility, so if the fragility score is above 70 or 75 out of 100, that lady's got a very high chance of fragility fracture, as opposed to someone who's down in the 15, 20 range, which is really good tough bone.
Well, we're going to link to that study in the notes because I read a lot of research and I loved that study. That was the study I read that really kind of clicked in my brain about the clinical use of REMS and the fragility index and how important it would be to get a baseline for my patients. So I'll definitely link to that study. I'm a huge proponent of early testing for bones, and I was always sending patients for DEXAs. Now I send them for REMS. I usually say from around the age of 50 that we want to get our baseline studies done. In Australia, the out-of-pocket costs for both REMS and DEXA is around $200. Usually women are not referred to do a bone mineral density until much later on. I think it's around 65 that Medicare will actually fund something like that. And I think that unless they've had early menopause before 45 or they've been on steroids for a long time, it's really not routinely offered. By the age of 65, a woman could have lost 30% of her skeleton. And that's when treatment can get really hard and limited. So when do you think people should start assessing their bone health, and any caveats on particular demographics?
I think that you could start by measuring it any time after peak bone mass. In my opinion, it is quite useful to have a REM scan between the age of 30 and when you start perimenopause. Why? You've got a baseline. You know where you've been coming from. So for argument's sake, if you've got a woman who has a body mass index of, say, 19, so she's in the normal range, but she's slight. If she doesn't have an understanding of where her baseline bone density is, when she hit peak bone mass, where was it? She's likely to be in the definition of, according to the DEXA, she would be osteopenic, but she may be tough. So knowing where you start is a really good point to sort of work out where your bone health is after that. Definitely, if you don't have that, when you hit perimenopause, then testing before that, I think, is also quite useful. Now, we know that the public health screening programs are never going to accept this. The US PSTF, that's the Preventative Services Task Force, came out in January, and they've reiterated again that population screening for bone health should be 65 and above, unless there are special circumstances. However, we're not dealing with that population. We're dealing with a population of women who are very interested in themselves. They want to maintain their bone health. They want to proactively make sure that they are well into their 50s, 60s, 70s. They don't want to live long badly. They want to live long well. And to know to help you live long well, you've got to start off by knowing what your parameters are. So definitely one scan prior to or around the beginning of perimenopause. And as soon as you diagnose menopause, now, whether you're going to have HRT or not, and ideally one would be offered HRT and have a conversation, then I think you need to know where you are at the beginning of that slope, because you know that in the first 10 years after menopause, without hormones, a woman will lose up to 2% of her bone mass per year.
Whoa.
So this goes to the point you made, and that is at the age of 65 or 70, you might have lost 30% of your bone mass, because the average menopause is 50, 51 in the UK, probably the same in most Western countries. You're that 10 years after that, so you're 60 and you've lost 20%. Another 10 years when you're losing at 1% per year, you lost 30% by the age of 70. And then it's not too late completely, but it's very, very difficult to get it back from there. So knowing where you are at the beginning of that slope and being able to do something about that, I think is really important.
Yeah, great. So ideally, we get it at peak bone mass, and then we get it at perimenopause, and then we get it again once menopause has been confirmed. I think those three key points of life are absolutely so easy to do these days as well. Now, talking about the postmenopausal woman, I read some fascinating studies around mini trampoline being helpful from a bone mineral density. And then we've also got research came out of Queensland called the Lift More study, which showed benefits of resistance exercise. What do you think that we should be doing from an exercise perspective to keep our bones strong and healthy?
So the data that you're talking about regarding the rebounder was really impressive, because it wasn't just about bone health. It was also about balance. It was about fear of falling, preventing falls. So it was much wider than that. A rebounder is a phenomenal bit of kit. You know, this small trampette that you can have good fun on, and at the same time, you can make your muscles better, you make your bones better. We're not just talking about bones here, we're talking about muscles as well. Osteosarcopenia is one of the biggest problems we have in an aging population. If you don't have an active population, then they are going to lose muscle bulk and they will get sarcopenia, which will then predispose them to fall, and then they're going to fracture as well. So the rebounder exercise regimes very much osteosarcopenia. Belinda Beck's Lift More study was about resistance and impact. So his favorite, high impact and resistance training. To begin with, the Lift More study was a groundbreaking study, phenomenal. It came out of Griffith University in Brisbane, a great place. I know Belinda quite well. I know her current PhD student, Adam, and he's got a REMS machine as well that he's looking at a lot of the young Australian cricketers. So really vibrant research unit there. And they produced a phenomenal study showing that you can have supervised lifting and impact. I mean, these are women who had low bone density, i.e. osteopenia, or very low bone density osteoporosis. And they were doing exercises, impact and resistance exercises and supervised lifting, not one fracture.
Yeah.
Fantastic. So Lift More was really a groundbreaking study. And when you look at the whole of the literature for exercise, we know that if a woman can do impact and resistance exercise and in all its forms, then she's going to do the very best she can do to preserve her bone health in the best state it can be.
Yeah, and I think that they're very easy. You know, resistance exercise and a rebounder is very easy for most women to be able to access. There's a lot on YouTube alone these days. You can access so much more information now. Looking at nutrition and bone mineral density, I read some research that lower levels of magnesium are related to the presence of osteoporosis, and that 30 to 40% of the women in the study who were mainly menopausal had low magnesium levels. So do you recommend magnesium at all, or do you feel it has a place in bone health?
So we know about magnesium because it's actually one of the 11 key bone nutrients. When you think about how does bone form, everybody talks about calcium and vitamin D. Now, National Health Service in the UK, they don't go beyond that. But when you look at the literature, the nutritional science literature, we know that there are actually 12 key bone nutrients, but I don't include phosphorus in it because phosphorus is in everything. So very few people don't get phosphorus in yet, because if you eat any food, pretty much phosphorus is there. So the key here is that you've got to look at how does calcium get into bone to effectively meet up with protein to then make healthy bone. Calcium gets into the bloodstream from the gut with vitamin D and magnesium. And it then gets from the bloodstream into the bone with vitamin K2 and magnesium. So you have to have magnesium all the way to hold the pan of the calcium while it's having a dance with vitamin D3 to get into the bloodstream, and then has another dance with vitamin K2 to get into the bone. So magnesium is so vital. We should get it in our food. Magnesium is easily available in fibrous foods, lots of fruit and nuts and stuff like that, anything with fiber in. However, certainly in the UK and in Europe, there has been a degradation of the amount of magnesium in good food, because if you don't have organic food, then the nutrients in the soil have been depleted probably over the last 50 years or so. So it might be that women are not getting enough magnesium, even though they might have a reasonable number of portions of green leafy veg and fibrous foods, because the amount of magnesium in those foods is reduced compared to 50 years ago. They might not get enough. So therefore, making sure that a woman has 400 to 500 milligrams of magnesium a day is absolutely vital. And it's quite useful to do an audit of, are you getting it in food? If not, a bit of a supplement would be great. But primarily, each of your nutrients, don't supplement them. Start off with food and then fill in around the edges. Don't start off with, okay, these were my supplements, and then I'll go and have a horrible hamburger.
I couldn't agree more. I am known as the food as medicine woman. Food first, always. But yeah, really interesting point about the soil depletion of these nutrients. So something to think about. What about vitamin K2? How do you, all of these things are like a dance. It's like a symphony or an orchestra in relation to all of these nutrients and bone health. But I know in Japan that they use it a lot from an osteoporosis perspective. Where do you see its place being?
Just to correct that, I don't know if they use it a lot. They just eat a lot of natto. So vitamin K2 is otherwise known as the menaquinone. Vitamin K1, which is the clotting vitamin K, is a phyloquinone. So at least two types of vitamin K. I think there are many more, actually. The K2 comes in two types that are quite useful for us. That's the MK, that's menaquinone 4 and menaquinone 7. One's short-acting, the other's long-acting. So the MK7 is the one that's preferred by most people, mainly because actually you just need to take it once a day. So K2 is really vital in transporting effectively calcium from the bloodstream into the bone. Now, this is very simple. I'm an orthopedic surgeon. I don't understand nutritional science. Those people are very intelligent, way above me with that. But that's how I see it. It's the dance, as you say. And it's absolutely vital that you have enough K2 in your diet, because otherwise you can't transport the calcium to where it needs to be. But K2 also has many other functions within the body, and it's a really important vitamin. Like D3. D3 is not just about bones. D3 is about immunity. It's about cardiovascular health, etc., about healing. So really getting the right amount of K2, and the right amount of K2 is the minimum is 100 to 120 micrograms a day. The Japanese might be taking up to 500-600 micrograms a day. They can tolerate that. The only thing I'd say about that is that if you take more than 200 micrograms a day, you might be running into a little bit of problem with atrial fibrillation if you have that tendency. So that's one of the commonest side effects with women who have a tendency to AF. So yeah, really important. The studies from Japan show that K2 by itself is absolutely vital in maintaining bone health, and has also been demonstrated to reduce the fracture risk without any other treatment. So you're absolutely right. K2, really important. And yeah, so the vitamins that we really need for bone are vitamin D3, K2, B9, which is folate, and C. To get those 4 vitamins, the rest are basically minerals. And so it is then magnesium, calcium, phosphorus, copper, zinc, manganese, etc., and boron.
And I just would like to pick your brains in relation to calcium, because we know when women come in to see me, they often have self-prescribed supplements. Often what I see in women that have had a DEXA and been told they have osteopenia, they get very frightened, and then they go and buy calcium and they start taking kind of reasonably high dose calcium by itself. So I know that there's research that says around 1,000 milligrams a day is preventative. We want to get that through our diet if you can. But there's also some problems with taking too much calcium as well, right?
Yeah, so too much calcium, particularly calcium carbonate, which is otherwise known as too much of that in some women is going to produce some hardening of the arteries. So you get calcification in arteries. There was a good paper in BMJ Heart a couple of years ago that showed that women taking calcium carbonate supplements had a higher risk if they had aortic valve disease, of needing an aortic valve replacement, and also of actually dying because they had their acceleration of the aortic valve disease. So taking too much calcium is not necessarily great. To some extent, the hardening of the arteries is mitigated by taking decent amount of vitamin D3, because that then reduces the cardiovascular side effects. D3 is cardiovascular protective. However, what I would suggest women do is, as soon as they've got the diagnosis, is they do a calcium audit. And if you do a calcium audit and you say, okay, well, what food do I have? So maybe you have really good dairy, sort of you're living in Greece, you're eating a lot of Greek yogurt, maybe a lot of feta. So you're eating fermented dairy products, which have got high calcium, high in protein, high in K2. So you're really picking off some of the sort of really key components here. And the way to do that is say, okay, fine. Maybe I have dairy. Maybe I don't have dairy. Maybe I'm pescatarian. Fine. Go and eat some sardines. 2 sardines have got 250 milligrams of calcium in them. And therefore, that's a quarter of your daily dose in 2 sardines. It's amazing. Bony fish from a tin has got a phenomenal amount of calcium in it. But nuts, seeds, anything that's going to make another life is going to have calcium in it. Fruit, lots of citrus fruit has lots of calcium in it, and vegetables. The audit first. Find out how much calcium you've actually got in your diet. If you've only got 500 a day and you need 1,000, have another glass of milk, have another orange, add to it by something natural. Don't take a supplement if you can get it with food and it suits your food preferences.
Yeah, I think that's great advice. And I think as well, Mother Nature packages up her nutrition in a way where things are fairly balanced. So it's very hard to sort of overdo one particular nutrient in that way. So we're almost at the end of part 1. Any last thoughts around osteoporosis, Nick? It's such a huge topic, and I feel like we've only just scratched the surface of it. But what else would you like to share with us?
So 2 things really, one of which is that there was an interesting article in the end of last week, Daily Telegraph. So Daily Telegraph, one of the big broadsheet papers in the UK, it has a pretty good health section. And suddenly it says sardines. I mentioned sardines already. Sardines are my superfood, but basically about protein. So there's a lot of on social media about don't have too much protein causes acid, etc. But you have to have enough protein. Because if you don't have enough protein, you can't keep your muscles in good shape. You can't keep your bones in good shape. So I think as well as doing a calcium audit, a woman should do a protein audit as well, make sure they're getting enough protein in their diet. Now, we know that you need somewhere between 1 and 2 grams per kilogram of body weight of protein per day. So if you have a 50 kilogram woman, she needs around about 70, 75 grams of protein, which is quite a lot. And there's a measure of economic prosperity called the Big Mac Index. How much does it cost for a Big Mac in your city? Because it's such a universal thing. But you can also do there's a universal protein measurement, which is actually the sort of chicken breast equivalent. So if you have 100 grams of chicken breast, that's got 30% protein. So that's about 30 grams of protein. So you can then work in your chicken breast equivalents.
Right. Yes, that makes sense.
So our 50 kilogram therefore needs somewhere in the region of 2.5 chicken breast equivalents a day. Now, she's maybe not going to eat chicken breast, but she's vegan or vegetarian, but she's got to translate that somehow into where does she get that protein from? And it's so important that actually that the woman gets enough protein, because if she doesn't, then she's not going to have really good muscles. She won't have really good bones. And as she gets older, as people get older, they tend to eat less. Therefore, proportionally have to increase the amount of protein in their diet. Because if they keep the portions just the same, she's going to get less and less protein, more and more sarcopenia, more and more propensity for your bones to become weak. So increasing protein as a proportion of your dietary intake as you get older is really important. So that to me is key. That diet is the key with all the whole aspect of bone health. If you get the diet right, you start on a very firm basis, very firm sort of foundation. You can build on, but without the right diet, you can't build.
Yeah, exactly. And I will also link my favorite calcium calculator that I use with my patients. So I'll put that in as a tool for people as well to utilize. But great points around, the cyclical nature. If you don't get enough protein, you can't build the muscle, you can't support your bones. It's kind of feeding into a loop that we really want to try and avoid. So that one action of making sure you're having enough protein in your diet is going to really mitigate that side of things.
Yeah, absolutely right. If you fracture and you've done everything, well, there's nothing you can do about that. That's absolutely fine. You treat and get on with it. That's okay. And then you get onto a different subject, and that is about what medication might or might not be used. And that's effectively secondary prevention. But we're talking about primary prevention here. Primary prevention should be about diet, exercise, lifestyle. If you look at all the studies, things like Lift More and all the other exercise studies, if you look at the nutritional literature, a high protein diet that's got all of the key bone nutrients in the right amounts, included with a resistance exercise, is just as effective at preventing fractures as any medication that you might be taking without the side effects.
Yeah, exactly. Wow, I've taken a lot of key points today. Our bones are so dynamic, they're always remodeling, which means that we absolutely can improve our bone health. They're not static. The importance of early baseline testing and being really proactive. So those time points of, around 30, perimenopause and menopause, I loved that. That's a very practical way that we can do that. And really just the holistic framework of healthy bones, as you said, nutrition and food is everything. We have to have that foundation before we start getting fancy with supplements and, overdoing things in that way.
Can I make an interesting observation? What's the National Bone Health Association in Australia called? I've got a feeling it's called Healthy Bones Australia. Now, to me, that renaming completely reframes the whole of the bone health story. I'll say please see that we still have the Royal Osteoporosis Society. We're talking about a disease. We've got to pivot all of healthcare in the Western world away from this reactive disease model to a proactive preventative model. And unless we can do that, we're going to end up with an increasingly ill society. And we see the same in the US, where you have this obesity crisis, you have this crisis of chronic ill health. And we've got exactly the same. Australia, the UK, is heading that way, thankfully. The new government came in last year and has actually need to talk about prevention. Now, one often said that, the NHS hasn't got a preventative bone in its body. That's a bit of overkill. That's not entirely true. But from the point of view of disease prevention, there's very little about prevention that's going on. So I think you're right. We need to encourage people to be doing the right things for themselves. And that is about exercise, it's about diet, etc. And it's about mental attitude. I mean, one of the things that if you don't get the mental attitude right, then you're not going to get all the other bits right.
Well, thank you for being with me today for part 1 of this series on bone health, Nick. Check out all the links. We're going to have links in the show notes for all of the information. Ask any questions below. Make sure you tune in for part 2, where Nick is going to use me as a case study for bone assessment. I look forward to seeing you then.